So welcome, I'm Megan Kingsley-Gale with the Hospital Practice Handbook Project, and welcome everyone to this event. It's so wonderful that you're all able to join today. So today's event is the Telehealth Roundtable for Hospital-based Acupuncture Programs. Today is Saturday, June 20th, and we are scheduled to go today from 9 o'clock to 11 o'clock Central. And this is me. I'm your event host and moderator today, and I am a volunteer with the Hospital Practice Handbook Project. So telehealth programs in hospital-based acupuncture practice, pivoting in the pandemic, lessons learned, benefits to the patients, benefits to providers, the system, issues, examples of innovation and discussion. So welcome everyone. So just as we start here, I want to do some housekeeping tech notes. Notice that we are recording, and to be able to, and this is a public event, so to be able to have this recording in good quality for those who listen to the recording later, I request that everyone stay muted with their video off and use the chat. Please note that when I am doing tech stuff or presenting, I am not able to see the chat at the same time, but you can certainly use the chat with each other, and I will be able to check it in between presenters. And again, all the questions for the panelists were we requested that they were in by Thursday, and I put together a series of questions and topics for the presenters for the panel discussion based on that. So if you have new questions that come up, the chat does get saved, and I can always look at those questions if they aren't answered today. Kind of look at what other resources we might have for you. All right. So a little bit about today's agenda. We're going to start with this introduction, a little bit about what the Hospital Handbook Project is, why this event, a working definition of telehealth, and then I will introduce our panelists. We have 6 panelists, and they're going to each do short presentations, about 10 minutes, about their subtopic related to telehealth and acupuncturists. And then we're going to follow that up in the second hour with panelist discussion, Socratic style of discussion. I do have topics to present to the panelists as part of that discussion. So where to find recordings of this event and the extra content? All of it will be co-located in the event's online resource module, and that's the URL there for the online resource module. For those of you who are attending this event live, if you have a Ticket Plus ticket, in your digital download for the ticket will be a coupon code to access the online resource module for free because of that as part of the ticket purchase price. For those of you who are watching the recording, you can go to this module directly, or if you chose the recordings only ticket option, in that digital download will be a coupon for how to access. When you log in on that URL, you put that coupon code in and you get free access to that resource. And all the tickets revenue goes directly to help with the outgoing costs of today's event. The goal is to make this public, but there are outgoing costs, including video editing. So we will make this public as soon as we can, and that will be available based on the revenue that you guys have helped with by buying tickets today, and for those of you who are buying tickets to the recording at a later date. So thank you very much. This is very much a community event and a community resource. We're all working together, so this is wonderful. All right. So again, that online resource, it is already available. So for those of you who got your tickets early, you can already log into that online resource and see some early access content that I uploaded as a big thank you for those of you who bought tickets early, or earlier than today. And it will continue to be available. So there's some extra content in there, and this is what it looks like when you log in. You go to that URL, this page will come up, and this is what it looks like inside here. So we got the extra prep information, and then today's recordings will be uploaded right here. So a little bit about the Hospital Practice Handbook Project. So this is a wisdom sharing community for hospital-based acupuncturists and their sponsors. And by sponsors, I mean, managers, hospital administrators, medical directors, anyone who is sponsoring your work in the hospital or an advocate for you at the hospital. The goal of the Hospital Handbook Project is to avoid reinventing the wheel, to share wisdom, have discussions, identify issues, share solutions, and grow together. So we are professionally growing together by connecting to each other, by not staying in silos, by sharing wisdom. So this is how we grow our professional community. The project is a not-for-profit community resource, and my time and my work is 100% volunteer. And in 2019, I noticed that there were 4 types of colleagues that were using the resource. And so I started in early 2020, late 2019 and early 2020, I started reorganizing the resources for the project to make it easier for each of these types of colleagues to access. So the 4 main types are students and prospective practitioners, the new hospital employee, that's from being hired, going through the hiring process and those first 5 years plus of being a new employee, for our leads and program managers and the hospital admin. And some examples of recent wisdom share work that I've been hosting with the Hospital Handbook Project is in March through May, I hosted both online social media and live Zoom discussion sessions on at least weekly on pandemic prep and response, because that was just a big need that our community had, and I was able to host those discussions to help everyone pivot and share examples and just have that discussion space. So that was wonderful to be able to do that. This event, obviously, is wonderful. This is our very first online event. So welcome to everyone, and thank you for being here. And then new this summer, we've got the Issues in Hospital Handbook Project, Issues in Hospital-based Practice webinar series that has started. And if you're new to the Hospital Handbook Project, I recommend you check out more of this information and learn more about us at our vision statement at our blog at that URL. And this is a review of the public resources. These resources are available to the public. We do have some closed discussion group resources as well. This is a little bit more about the Issues in Hospital-based Practice webinar series. The URL is above. And there's already some content included in this monthly module. And the next in the series, starting later this summer, is the Professional Practice Standards series, where we talk about the Joint Commission definition of what professional practice is, our BLS, Bureau of Labor and Statistics, Standard Occupational Code, documentation standards for professional practice, and professional practice evaluation, both FPP and OPE, and looking at what is professional work versus what is technical work and how that relates to working in hospital-based practice as an acupuncturist. So you can support this community resource in these ways. Start by joining the email list if you're not already on it, and then we have these other options. So today, telehealth programs and hospital-based acupuncture practice, pivoting in the pandemic, lessons learned. So why telehealth? So in non-pandemic times, telehealth helps us with access to care for patients and providers. When patients cannot attend appointments due to lack of transportation, or a patient lives far away and travel time for appointments is excessive, having the option for telehealth is really helpful. During the pandemic, telehealth has really hit its stride with stay-at-home orders, remote work providers. It's great for healthy providers who are quarantined. They can still provide clinical care. Healthy patients who are quarantined still have access to some care. Sick patients who cannot attend clinic in person can still receive some health care because of telehealth. And providers with school children at home can still do some part-time work remotely via telehealth and other remote work options. Telehealth is useful for providers who are high risk, helps them to remote work, and providers who have dependents who are high risk. It gives them the option of remote clinical work. So why this event? And so I talked about how I was hosting those community discussion sessions, Zoom sessions and online sessions mid-March through May. And out of that came a real need, a consistent need to do even more on telehealth, particularly to host our own conference on telehealth. So why a telehealth event specific to hospital-based acupuncture programs? As you all know, telehealth capability is critical for all clinicians in the phase clinic opening, closing as communities respond to the pandemic. Some organizations had a telehealth program in place before the pandemic, but many stood theirs up during the pandemic as a way to support and protect both provider personnel and patients during a respiratory-based pandemic. And some are still in the process of standing theirs up and looking to the community for examples that match their system or that more closely match their system. However, not all systems have been supportive or understanding of how acupuncturists can work via telehealth versus in-person care, citing lack of access to current examples. So here we are presenting in this event, this public event, presenting current examples of telehealth programs in a hospital-based acupuncture practice and having professional Socratic discussion on the related topics. So this is wonderful. So Ralph Waldo Emerson wrote, "Do not follow where the path may lead. Go instead where there is no path and leave a trail." And I feel like all of the acupuncture program presenters today have very much done that when they're pivoting with the pandemic and setting up their telehealth programs. They have definitely made a path, and by sharing their examples and their wisdom today, they are showing us that path, and they have left a trail for us. So this is wonderful. So a little bit about telehealth. This definition about telehealth is that this came out, and it was published in a paper by the Duke University team in May 2020. And I like this definition because it's a very big, encompassing definition. I have the citation below for you. So this definition of telehealth refers to the entire spectrum of activities used to deliver care at a distance without direct physical contact with the patient. Telehealth encompasses both provider to patient and provider to provider communications and can take place synchronously, both telephone and video, asynchronously, patient portal messages, e-consults, and through virtual agents such as chatbots. Some organizations have that ability with their patient portal system, and wearable devices, which is a part of telemetry. So I want to introduce our panelists and their subtopics. Just to note that Christine Kaiser was on some of the marketing information announcements for this event, and she will not be presenting today, but we are going to set up a recording with her later, and she will present an update on her telehealth program, and that recording will be available in the online resource module. So these are our panelists. We have Paul McGee, lead acupuncturist at Allina Health, the Penny George Institute for Health and Healing. They'll be talking about their telehealth program, both inpatient and outpatient. John Burns, Dr. John Burns is manager of acupuncture and mind-body therapies at Aurora Integrative Medicine, Advocate Aurora Health, which is located in both Wisconsin and Illinois. Dr. Julie Olson, who is the national lead for acupuncture, Integrative Health Coordinating Center of the Veterans Health Administration. She'll be talking about telehealth, acupuncturists, and the Veterans Health Administration. Galina Rufiner, licensed acupuncturist and Chinese herbalist at the Cleveland Clinic in Ohio. Galina is well known for her work in bringing Chinese herbal medicine into a medical center and working with quality assurance for that process. Today she'll be talking about Chinese herbal medicine and telehealth. Maury West is our coding and billing expert on the panel today. She works at AcuClaims. And Dr. Nancy Gales, who is CEO of Health and Harmony, Wellness Education, Telehealth and Harmony. She is a policy consultant with the Integrative Health Policy Consortium, and she will be our panel expert on federal health policy as related to integrative health practitioners and telehealth. All right, that is the end of my introduction. Welcome everyone, and we're going to start with our first panelist, with Paul McGee.
All right, am I good? You can hear me?
I can hear you. Just one moment.
Of course.
One. Welcome, Paul McGee.
Thank you.
Paul.
So, obviously, my name is Paul McGee. I'm the lead acupuncturist for Penny George, the Penny George Institute for Health and Healing at Allina in Minnesota. The Penny George Institute was founded back in 2003, and we are part of, we're considered a branch of medical specialties for the Allina health group. Alina is a very big health group. We've got 13 hospitals and over 90 clinics in both Minnesota and Western Wisconsin. And before we did a little bit of a furloughing shutdown for the COVID pandemic, we had 35 acupuncturists spread across our system in various roles. We have more than acupuncture at the Penny George. We also have integrative nutrition. We've got exercise physiologists. We've got both doctors and nurse practitioners that that practice integrative and functional medicine. But I'm the lead of the acupuncturists, and we've got by far the most providers in the whole system. So in terms of our hospital-based inpatient people, we've got about 7 acupuncturists that are dedicated to that particular role, and 8 in some of the more regional hospitals that float back and forth between inpatient and outpatient. We're in a sort of maybe potentially unique situation in that the cost for our services is budgeted into the operating costs of the hospitals. In our inpatient settings, we don't bill insurance in any way, shape, or form. So it actually makes a little less, it made in some ways shifting to telehealth in the inpatient world a little simpler for us. The primary focus for our services in inpatient is in our mother-baby centers, in our oncology support, in our joint replacement centers, and also supporting our pain teams, which are the MDs that are going around our hospitals and are the ones who are responsible for dealing with all of the breakout pain. I did do an earlier presentation, which I think we have recorded for our original pivot to telehealth in the inpatient world. Just to update that slightly, our numbers continue to get better and better in terms of being able to get through to patients. We are continuing to gather data from that. We're still getting both before and after pain scores, anxiety scores, nausea scores, and coping, just general coping with their situation scores on each of those encounters. I think that one of the main reasons why it's working better is that we're actually getting more of the nursing staff in the hospitals to kind of know that we're there. And our providers will often touch base with remotely on the phone from home. They'll touch base with the charge nurses, and they get kind of the usual breakdown that they would have gotten in person as to who's the high priority patients to be seeing. So that's going well. We did actually have a struggle with one of our service lines in terms of them not wanting to do telehealth. And that was in the inpatient world, that was our mother-baby centers. And they were very less receptive to the idea. And we ended up having to furlough some of their providers for a few months, although they're beginning to come back, and we're setting up in-person services there again in the next few weeks. In terms of outpatient, not actually for patients that are checked into the hospital services, our providers in that sort of area are spread across some standalone clinics that are just Penny George. We've got a couple of hospital-based clinics which are attached to hospitals and are billing at a slightly different rate than everyone else. And we also, the majority of us are now embedded into primary care sites across our system. We've got about 28 acupuncturists in that particular role. 8 of those are the sort of people floating back and forth that I was mentioning before. And all of those services are either billed or out of pocket. And we actually had a decent amount of challenges trying to get ourselves pivoted into telehealth in our outpatient world. One of the first ones is that we are actually, being a slightly older organization, we have not been necessarily as agile as we should have been in terms of being up to date with certain billing practices. We're just now beginning to transition into doing E&M coding. Forever we were just doing the 15-minute increments of acupuncture. And then the fact that we were part of a huge system actually, as the whole system was pivoting to telehealth, we ended up having we ended up being low on the totem pole in terms of resources. And so it was, and I agree with this, it was much more important for our system to get the cardiologists and the endocrinologists set up. They both are dealing with things that are much more life-threatening than we do, and frankly, they get much more income for their visits than we do. And all of the shifts to all of the back of house build outs in terms of our getting access to telehealth connected to our electronic health records, that all those priorities, all those resources went into other service lines first. And so right about the time that we were in line to start getting that up and running in terms of getting video visits with our patients, we were starting to push back into seeing people in person. And so it is something that is long-term going to be still something I think we develop, but I am pushing us to go much more into the in-person, or to go much more to the in-person services. We did, however, have some successes even in the outpatient world trying to get ourselves built into doing some of the telehealth. We were entirely working by phone. We were only doing retail only because we could not quite get all of the billing things worked out with it, even within our system, working with revenue cycle management and provider relations in our coding department. That was many meetings, and they were all in many, many other meetings. But we did manage to get a few good examples of success. The people we were doing the most work with were already established, engaged patients, and they were the patients that needed updating, and they needed to have their herbal medicine sort of tweaked, renewed. So we didn't have much. We didn't have much success with the outpatient world, but the inpatient we did manage to get a decent amount of. We got the transition done at least. So let me glance over my notes for a second.
That's wonderful.
Yeah.
So while you're looking at your notes, I just wanted to mention to everyone that Paul did do a recording with us earlier in May, and that is up on our YouTube channel, and that was really specific to their inpatient telehealth pivot, which was really unique. So for those of you who haven't seen it yet, it is also in the online resource module that I mentioned, but it is up because we had sponsorship from very generous sponsorship from Sandra Grassa. We were able to get that up on the YouTube site as well for those of you looking for that. All right, did you have anything else that you want to talk about, Paul?
Well, actually, I can just answer a particular question that I just got from Sneha, it looks like.
Yeah.
The acupuncturists in our inpatient world are getting paid, we're all salaried, and we're offset in the inpatient realm by, we're essentially line items in the hospital's operating budget. And the way that we continue to, the way that we prove that we're worth it is by the data that we're collecting in terms of patient outcomes. And so we gather the number of patients that we've seen, and this is how much we've changed their pain scores and their anxiety scores, and that's been enough so far to continue to have the hospitals fund us. In the outpatient world, we are generating our own income, and that's what offsets our salaries.
Okay, great. Thank you very much, Paul. I'm going to, John, I'm going to pull up your slide next. Just one moment. Please welcome Dr. John Burns, Manager of Acupuncture Mind-Body Therapies at Aurora Integrative Health, Advocate Aurora. Welcome, John. And John, just let me know when you want me to move forward with the slides.
Great. Thank you, Megan, and thank you everyone for joining this forum. I think it's a great way to learn from each other. I love that quote you started with, Megan, that we need to go where there is no path. If you look at the symbol for Tao, it literally means put your head over your foot, to be more aware so you don't trip along the way. And it's not been easy. And what I'd like to share with you today is the programs that morphed from one into the other and all the processes that basically were behind all of this. I've been working closely with my director, Nancy Conway, our medical director, Dr. Sarah Pierce, and Stephen Moy, a wonderful acupuncturist up in North Fond du Lac, has been helping me trying to bring telemedicine, telehealth to our patients. So next slide. So yes, I work for Advocate Aurora Health. I'm very pleased to be part of this project. Next slide, please. I have nothing to disclose financially, no financial relationships with this project. I love the relationships I am building now with everyone on this panel. Hopefully we can communicate after everything is said and done. My objectives for you today is to talk about the critical need of telehealth during this COVID pandemic. I also like the title, Pivoting in the Pandemic. This is what has been required of all of us to be able to turn on a dime, so to speak, and be poised to move forward to help our patients live well. Next. We are a large organization. Aurora merged with Advocate a couple of years ago now. We have 500 clinical sites, 27 hospitals. I just learned that Advocate Aurora is in conversations with Beaumont in Michigan to potentially merge with them. That would bring team members up over 100,000. So that's a large organization, but we are a small department. Next slide. So our department, what my job is basically in our department, and our department consists of, as I mentioned, the director and the medical director, but we have fellowship trained physicians, 22 in fact, that went through an integrative medicine program. We have chiropractors, over 20, massage therapists, over 30, integrative health coaches, and now we have 14 acupuncturists spread between Wisconsin and Illinois. We were asked to pivot, so to speak, to meet the critical needs of the COVID pandemic. We were asked to come together on a Sunday morning for emergency meeting to determine where we were going to go, since the governor had put in place safer at home orders and non-essential healthcare procedures were being discontinued for the immediate future. We were given a choice. We could be furloughed, and being furloughed meant you would still be paid your salary as well as benefits. You didn't really have to work, or we could choose to work from home and be paid our salary and benefits. I was very grateful for all of our acupuncturists to step up and say, we're going to work from home. And our work from home provided us wonderful competencies that we can use as we move forward, such as auricular medicine, TCM fertility, as well as TCM pediatrics. We're currently working on competencies to address the sequelae of the COVID pandemic. Next slide. And this is where the programs started to morph one into the other. Right after we chose to work from home, we realized that the greatest predictor of health outcomes, whether it's a surgeon, a psychologist, a physical therapist, or an acupuncturist, is the therapeutic alliance. We did not want to lose our therapeutic alliance with our patients. We know this is crucial for their health and well-being. We also understood they may have feelings of abandonment because we are not allowed to see them. So right from the get-go, we offered complimentary or free telephone visits to reconnect with our patients, to give them answers to what we needed to do and answer any questions they had in regards to where we go from here. We are starting to see also at this time referrals to acupuncturists, because some physicians were still referring services to acupuncture, even though we are not providing services. But what we wanted to do is connect with those patients, specifically new patients that needed answers to their questions. We call it a Get Acquainted telehealth visit, which was free. And we are continuing to do this as we start to re-enter, thankfully, basically in the last 2 weeks. Next slide.
John, I just wanted to mention 5 minutes.
Okay, with this understanding that we needed to reduce the traffic within the hospitals, the oncology leadership said there would be no visitors for patients undergoing their chemotherapy treatments, and we know that that can be very stressful. We started a complimentary day 1 chemo 1 treatments to meet this need, and that's where we are currently. Since May, we are offering these services. When patients go in for their first chemo treatments, we can connect it with them through an iPad or an iPhone. Next slide. What we needed to have in place, though, is something beyond needles. We needed to have directed therapeutic strategies. So when we talk to patients, we want to let them know we are more than just needles. We offer all types of self-care strategies that they can take with them home to enhance their benefits of an acupuncture treatment. Next slide. What we created is these rehearsal strategies where we were all consistent. We would provide them lifestyle management, mindfulness, a great ear massage video, acupressure, as well as Qigong, and Zoom Tai Chi classes, which Stephen Moy just started last week. Next slide. The process then to bring this to a billable telehealth service has been a path. What I needed to do is address all of the people associated with the slide deck, from senior leadership to people who were in charge of coding and billing. Next slide. We had to give a request to leadership to let them know we were more than just needles. There was some laughable moments when I asked that we provide virtual acupuncture, and they said, how are you going to do that? I said, we're more than just needles. I had to reach out to coding to recognize these specific E&M codes for our billable services. I forgot to mention that Anthem now covers all team members at Aurora for acupuncture services, and they did agree to pay for these CPT codes. And then we needed to have the access to Epic and Haiku and Canto and Zoom. I'm happy to say just yesterday, after 2 weeks, all of our acupuncturists now have access to use Epic through Haiku and Canto. Next slide. So the future of this is to bring acupuncture to where patients live, using our social media and platforms to treat them not only in person, but wherever they go, and to enhance their treatment outcomes. I think this is a silver lining that we as TCM practitioners can really help patients' body, heart, mind, and spirit. Next slide. And I always refer to this as a good TCM physician, you can heal a disease. Very good physicians can learn how to prevent disease, but in this time of unrest, civil unrest, and uncertainty from the COVID pandemic, we need to heal society. And I think together we can. Next slide. And I would like to thank everybody. Thank everybody for what you're doing. We are going on a path that has not been laid down for us. And I think I want to thank all of you.
Very nice. Thank you, John. And for those of you who want a longer presentation of John's, he did record a longer presentation with me on Tuesday, and that is up in the online resource module. Please welcome Dr. Julie Olson. She is the National Lead for Acupuncture Integrative Health Coordinating Center, the Veterans Health Administration. So Julie, just tell me next slide when you need me to.
Great, go ahead right now. Well, thank you first, Megan, and the Hospital Handbook Project, and all of you who've come today to see this presentation. I'm really excited to be here, and it's so fun to see all the innovation and great work that's being done in this community, and really moving forward the profession of acupuncture throughout the United States. It is so exciting, so I'm really happy to be here. So next slide, please. So at the VA, we're a little bit unique in the type of acupuncture that we provide. We do have now about 71 licensed acupuncturists that have been hired and working in the VA. The majority of those have been hired in the last 2 years. So it's very interesting to bring this group into a large medical system. And then we're faced with this new challenge of how we're going to practice during a time when we're not able to see our patients face to face. We also have a significant number of medical acupuncturists and chiropractic acupuncturists who have fewer hours of acupuncture training than a licensed acupuncturist, but they are also out there delivering acupuncture care. And when we talk about how we pivoted to deliver telehealth, we also included these providers in that care. We also have some limited scope acupuncture providers. So these are providers that are capable of performing battlefield acupuncture or the NADA protocol within the VA. So they have very, very limited training. Often it can be just 4 hours of training for a nurse to provide only BFA, only to be able to insert the needles in those specific points. But they had a panel of patients that they were regularly seeing with BFA, and then we had to try to help them figure out how to continue to deliver some form of care when they weren't able to do the BFA. So next slide, please. We do have a significant amount of group acupuncture that's being done in the VA. We have a tremendous need, of course, for the utilization of acupuncture, and we don't nearly have enough providers. 127 medical centers, and then we have community-based outpatient clinics. We have veterans who live in very rural environments as well. So we really are constantly fighting with access for our population. No dearth of patients to see for our acupuncturists. And that is a part of the reason why we have so much group acupuncture. Group acupuncture can be an auricular clinic, it can be a comprehensive clinic where we're doing full body acupuncture, all sorts of different things are being done. But of course, with COVID, we are no longer doing groups, and some sites initially pivoted to individual sessions from group, and as we're coming back online and providers are seeing their patients again, groups are still not really happening. The majority of our face-to-face appointments have been canceled. Now we're getting those back up. And we really had the question of how do we support our patients virtually? And as some of the other presenters discussed, we did have those snickers and giggles of how we were going to stick those needles through the telehealth wires. And so I really looked at this, it was one of those moments where you go, wow, we have not done a good job of presenting our profession to the medical community in a way that they understand the broad capabilities of an acupuncturist. So I really look at that as a personal goal of mine to make sure that there's a better understanding of our broad range of skills. And, we all, I think, know that self-care is a really important part of especially long-term chronic pain care. And the majority of the patients that we acupuncturists are seeing in the VA have chronic pain. About 80% of veterans have chronic pain. So we know that, this is an important period of time where we can focus on that self-care piece. There's going to be plenty of acupuncture that still needs to be done, but we want our patients to be as independent as possible at home. Next slide, please. So, the benefits of telehealth, I think, are probably well known to you all. It increases access, but during this time of physical distancing, we were really concerned about losing contact with our veterans. There's a significant problem of veteran suicide, and we do want to just maintain that closeness. Maintaining the therapeutic relationship with the acupuncturist and the patient was also important to us. And we also thought of it as a chance to reach out to our patients and make sure that they understood some of the basic skills that they need to do to prevent becoming infected. Are they doing proper hand washing? Various things that we can just talk about as medical health professionals about how a person can stay the most safe. We also felt this really was an opportunity for our acupuncturists to contribute to the larger medical center, to the veteran population. And a lot of the things that we created as acupuncturists have been used by a variety of providers. We created some acupressure sheets, and we have many different non-acupuncture providers that are offering those to their patients as well. For the future, we're looking at telehealth to continue and thinking about the low cost of it, zero travel. We pay veterans to come to some of their appointments depending on their level of disability. By that, I mean we pay for their travel, we pay for their vehicle expenses. And so Also, depending on a patient's rating of disability, they might have to pay a copay when they see an acupuncturist at a VA medical center. And the copay for acupuncture is $50, which is rather high. So this is a way when we're providing acupuncture care that there is zero copay for a veteran that comes in. Next slide. I wanted to show you the great stuff we have at the VA. This is all some of the equipment that we have. We have been providing telehealth at the VA for a long time, and many of these different units are available in different places. Like that wall dock unit is something that we might have in a retail clinic. We've had an agreement with Walmart to provide some telehealth space for the VA so veterans can come in to a clinic within a Walmart and see their doctor via telehealth, and a unit like that might be used. The one with the big eye, we have ophthalmoscopes, otoscopes, all sorts of different equipment that can be used. Usually that's with a health technician that can use that equipment and work with a specialist. So if you were working with a retinal specialist from your primary care doctor's office, they could maybe show deep into the eye to the retinal specialist, and together they can work together like that. So a lot of cool stuff that we've had. Telehealth has been a part of the VA for quite some time. We do a lot of tele-ICU. There's questioning whether or not tele-ICU will be mandated in every ICU or not. There's some discussion about that. And then we do a lot of asynchronous visits with radiology. So of course, if you had an MRI done in New York and it was midnight, maybe it's still 5 o'clock in Hawaii, so we might have a VA provider in Hawaii reading that MRI. That way we have coverage. We also do a lot of teledermatology, where a primary care provider might be able to take a picture of a lesion, send that off to a dermatologist, and get a report back. Next slide.
Really, just 5 minutes.
Sure. So when we first started, the platform that we use in the VA is what we call Veterans Video Connect. And this is our main platform for telehealth. When we initially started, we ended up not having enough bandwidth on this platform, and they did increase it. But right at the start, when we all of a sudden had just so many providers working virtually, we did allow the use of many other platforms, but we've pulled back on that and gone back to just VVC because we find it to be the most secure for our patients. So that's mostly what we're using. Next slide. And we do have a consent process that we do with a patient when they are meeting us in a telehealth environment, that they agree to having this type of care this way. We have a lot of security that we do. We make sure we know where the patient is located when we're talking with them. If they were to have an event, a fall during a session that we're having with the patient, we would want to be able to send emergency providers to their home. So we get the local contact for police. We need to know where they are, how to contact them, because of course you could just have the video fail and you're not sure if the patient is incapacitated or if it's just a video failure. So a lot of that behind the scenes goes on. I wanted to share with you. Next slide. Things that we're doing via telehealth, of course, acupressure guidance, nutrition, stress management, mindfulness, therapeutic movement. We also have a lot of virtual group classes that have been going on, mostly with Tai Chi, Qigong, yoga, and some mindfulness-based stress reduction type of techniques. Next slide. These are some of our acupressure handouts that we've developed. So the one on the right has a few routines that you could do. And then the one on the left is meant for a provider to then select among these points. The one on the left is actually a couple pages. So they're very common acupuncture points. So an acupuncture provider might be able to go through and say, do 1 to 7 and 12. Or that's the point prescription I want you to do with acupressure. Next slide. And I just wanted you to be aware of all of the resources that we have. You should be able to link to all these. I had Megan double check that these all work. So we have a lot of videos that have been created through different providers out in the VA. We have a couple apps that are great, the Move Coach, the Mindfulness Coach, the CBTI Coach, so that's for insomnia. And I just wanted you to have some context there and be able to get to those. Next slide. Yeah, I think that's it.
Okay, thank you very much, Julie. One moment here. Please welcome Galina Rufiner. She's licensed acupuncturist and Chinese herbalist at Cleveland Clinic. Welcome, Galina.
Hello, everyone, and thank you very much for an opportunity to introduce our program. We actually started with telehealth way before the pandemic. I have been working on our telehealth program for last 4 years. The story was 6 years ago, we initiated traditional Chinese herbal clinic, and this is a full-blown custom prescription clinic. 4 years ago, administration of my hospital approached me with opportunity of a telehealth program for herbs. At the beginning, I said, no, I will have troubles to do the telehealth. Let me think about it. So we started our telehealth last year, approximately in August at Cleveland Clinic. And in my private practice, I have been doing telehealth since very beginning of last year. So a lot of the time which I had on my hands were devoted to the proper practice standards in our profession. Next slide, please. First, I want to obviously to disclose that I don't have any financial agreements with any of the companies presented in this presentation, and this is not a substitute for legal advice. You are in education only mode. Next slide, please. Very common question which we get from our profession. I am not a medical doctor. Do I need to comply with telemedicine law? The answer is, if you are a licensed certified healthcare provider in any state, offering individualized consult, collecting personal information, reviewing health history, performing an assessment, establishing diagnosis, and creating treatment plan and recommended treatment, you are subject to federal and state license and regulation and practice law, including TCM and telemedicine governing law. So please pay attention that it's both telemedicine and acupuncture law, and they might be very different dependent on the state. Next slide, please. Next very important subject is HIPAA requirements. Which telehealth platforms you use? And please remember, we are still paid to the face-to-face appointment. In non-COVID time, you have to see patients visually. Very temporarily during the COVID pandemic, HIPAA requirements were relaxed, and you could communicate with the patient via email, via telephone, via FaceTime or Skype, but not so in normal time. In normal time, your system has to be very secure, and there is 2 ways of communication: via platforms which are integrated with your electronic healthcare record systems, or via specific telehealth apps. And I will give for you some examples later. So please, next slide. So here's an example of Telemedicine App Platform. This one is a VC Clinic. That is the one which I use in my private practice occasionally. The big benefit of telemedicine app platforms, and I would suggest for you use paid version. In very many cases, billing for telehealth is still unclear. It's maybe not payable, or like in state of Ohio, because we don't have an opportunity to bill EM codes because of our acupuncture law. It's all cash service. So then you are using telemedicine app platform, there is an option for the patient to enter their credit card, and you can bill them at the end of the visit, or if insurance company rejected that. In Cleveland Clinic, we use American Well telehealth platform for our Chinese herbal medicine clinic. There is the same version. Patient pays upfront by entering their credit card. Next slide, please. So here's an example of EHR platform. And again, since that presentation was mostly intended for a majority of our practitioners who are in private practice, This one comes from Unified Practice, and during COVID emergency, Unified Practice actually was polite enough to offer for acupuncturists no additional charge for telehealth platform services incorporated with Unified Health Practice. And on the screen, on your left side bottom, you see how it looks in real time. You will see the patient face, patient sees your face, and simultaneously you can complete your charting. Next slide, please. So again, talking back about standards for telemedicine, and please remember, even in times of COVID, this was not relaxed. You still, according to the law, have to be licensed in the state where the patient resides. So, like, let's say I'm licensed in 2 states, in Ohio and in Florida. First of all, I used to live in Florida. I still have a lot of patients in Florida. Plus, we have a lot of snowbirds who are in the winter time in Florida. So I see quite a few of them via telehealth for our herbal clinic. But coming back to standards for records, one of the reasons why it took for me about 4 years to figure out our telehealth platform, you still are obligated to do exactly the same assessment like you do in person. I had really serious troubles to figure out how to collect reliable tongue objective sign and pulse objective sign. That one was the longest, but it's all doable, and we will discuss it. Next slide, please.
Okay. Galina, 4 minutes.
Mm-hmm. So here is information which must be in your SOAP notes independently. Is it in-person visit or is it a virtual visit? You just must notate in your notes that this is virtual visit or this is in-person visit, and accordingly reflect appropriate billing codes in your documentation. Next slide, please. Here are how I collect objective science of TCM Tongue and Pulse. This is from my private practice EHR system. In Cleveland Clinic, we use Epic, but recording is about the same. I'm still capable to copy and paste patient tongue photograph, which patient uploads to our American Well platform, and I download it on my end to the computer screen, and after that I transfer it to Epic. And it all happens via completely HIPAA compliant American Well telehealth platform. The same with Pulse. For Pulse gathering, I use mobile EKG technology. So my patient just needs to buy an electrodes for mobile EKG, which cost negligible, which $89 or something like that. Apple Watch 4th generation already has built-in EKG option. So all which patient does just uploads, again, via HIPAA compliant American Well telehealth platform PDF of their pulse, and I translate it into my electronic medical records in Epic in Cleveland Clinic or in my private EHR system. Next slide, please. Because our telehealth program is specifically designed for our herbal clinic, I do not provide any other services via telehealth. It's primarily just an herbal consult. At large, as a department, we are still toying with the idea how to provide acupressure services for our patients, how to provide Tai Chi and Qigong. But the big issue, like in many other healthcare systems, is billing requirements. With our herbal clinic, it's a cash service independently. Is it in-person appointment or is it virtual appointment? So, and because we established way before the COVID, we had any problems to switch to that. And even working from home, via COVID emergency, I still was seeing my virtual patients in exactly the same manner like I was seeing them in the hospital, just from home settings. So here I put for you an herbal pharmacy selection guidelines. And that's where I believe our model is pretty unique. We do use third-party compound in herbal pharmacy, exactly like any Western MD has, because we are consulting providers, we are procedure performing providers, we are not a pharmacist, we are not paid for dispensing time. Plus, there are difficulties with the space availability in the hospital setting, so we just found a good qualified third-party compounding pharmacy, and they fill in our prescriptions. And just in the future, if your hospital administrations or physicians which you are working with are asking about quality and regulation for traditional Chinese herbal medicine, please note that we are regulated by FDA accordingly to CGMP regulation under Title 21, CFR 111. Next slide, please. Here I provide for you a label because that again comes back to the practice standards. According to FDA requirements, all herbal prescriptions must have FDA compliant label. We use Crane Herb Pharmacy as our third-party compounding pharmacy, and they were courteous to provide for me an example of the label for you. Please note that all necessary and required by law information is reflected on the label. If you use something out of the house, please make sure that you are in full compliance with regulations outlined in the sources on below of the slide. Next slide, please. So, patients deserve increased access to TCM herbal telemedicine. Please let us do telemedicine. Thank you very much.
Thank you, Galina. And as you guys see, her website for more information about her work is at the URL below.
Yeah, I do have quite a few different classes, including specifically step-by-step how we do traditional Chinese herbal medicine clinic in Cleveland Clinic. I have a large 4 hours class on telemedicine, including with all resources on the law, rules and regulations, practice standards, and there will be an upcoming class on ICD-11, since that another practice standard which we, especially working in the hospitals, must incorporate and have.
Please welcome Maury West, who is an acupuncture coding and billing expert. Thank you very much for joining us, Maury.
It's my pleasure. I am excited to be able to present today, and some of the information that I'm going to be providing, Julie touched on a couple of issues as well as Galina, but you need to hear this stuff more than once. I am a certified professional coder with the American Academy of Professional Coding. I am the insurance committee chairman of the American Society of Acupuncture. So let's get started. Next slide. So it's just important that you look at these things. What is your state law requiring telehealth? There were some states where state law was illegal for acupuncturists to practice telehealth. I believe Illinois was one, and they had to work to get that changed. So just these are the things you want to consider when you're deciding to provide these services. Look at your malpractice. See what it says about it. A lot of times, a number of malpractice people will revert back to state law, but I've seen them where they say they are specifying a certain type of equipment that you must use. Then of course, I'm about billing and reimbursement. So will the carrier pay for your services? You need to find that out so you can tell the patients whether it's going to be a cash base or whether you think you can. And I'm saying think because, and I'll explain to you why. It's all kind of new. This whole, when COVID took over, they relaxed all the rules. But the insurance companies were definitely not prepared, and I'll talk more about that. Most importantly, remember the patient must initiate the care. I'm hearing some acupuncturists that are contacting their patients and then saying, oh, we could do a telehealth visit right now. Don't do it that way. And again, you must have informed consent. And it has to be documented in the patient's record. Next slide. So informed consent, I won't belabor the point, but obviously you need to explain to the patient what the expectations are. What happens about a technical failure? How do you want to reach out to them between these visits? And then you will be coordinating with other healthcare professionals as needed, and then your policy for prescribing herbs. That should all be included as part of informed consent. Next slide. So there's 3 types of codes that we're going to discuss today. There's the online digital, and there is the telephone evaluation and management and both of these are for established patients. So one of them is completely digital, and the second is via the phone, and the true one is the virtual face-to-face. So those are the 3 we're going to discuss. Now there's also another set of codes that these codes are similar to above, but they are supposed to be used by physicians who are not licensed to provide E&M services. So like Galina was mentioning in Ohio. So, okay, next slide. So we're going to take a dive down into each of these types. So this is the online version. And what you need to know is you're expected to provide an E&M service to the best of your ability using digital means, but you don't have to hit those bullet points. Instead, we're going to look at time. And what I've given you is I've given you the Medicare average rates for both non-facility as well as in a facility setting. So you have to understand that this is for an established patient. It's a 7-day period. So if you saw the patient on Monday and perhaps you say check back as needed, you really don't want to bill out that claim until a week has gone by, in case there's been another contact or so, because you're going to total that time up and then bill it out. So you would never bill out a 99421 and then 2 days later bill out another one because you saw them for, say, 10 minutes each. Instead, you would wait, gather up the cumulative time and bill this, the 99422. Now, in private practice, very rarely will you even be able to use this because they're using services that some of the things that Julie showed that keeps track of all this automatically for you. Next slide. So, so again, this is explaining how it would work. You would use an online portal that would keep track of the time. And here's just an example. And then over a course of 7 days, you spent a total of 20 minutes with a patient, you would bill out that code. Next slide. So this is when you're doing telephone itself. The codes are the same process. It's based on the time you spent cumulatively. And then I should also let you know that if you're going to provide an E&M service within the next 24 hours, you don't bill this out. Instead, what you do is you see the patient and you bill out for the E&M. So again, these are cumulative. However, if you have had a previous E&M and you followed up with a telephone, or if you you have a telephone consult with a treatment with a patient and you decide that you need to do a complete E&M with them, virtually face-to-face, you're not going to bill these out. And again, the prices are for in-office setting and facility setting. Next slide. So here's an example of that, and you're going to, as Galina discussed, it's important that you do proper documentation. So you're going to take that history and you're going to record it in the medical records, and then you're going to instruct them to call back, and you're going to document the time. It's very important. In all cases, when you bill for time-based procedures, you have to have the time documented in your progress notes. Next slide.
4 minutes, Maureen.
Oh my gosh.
I know.
Okay.
Well, we can always come back during discussion too.
Okay. Just let you know, and everybody knows they've waived some of the requirements. Next slide. We're going to skip through this then. You can't treat a brand new patient using telephone or digital. It must be face-to-face. So you need to check on whether or not the carrier will pay for an E&M codes. Next slide. So here are new patient E&M codes. All I want you to know is you're going to want to stay away from the 99203s, because in addition to the chief complaint, history of present illness, and you're going to have to do an extended exam, and you're not going to be able to do that using virtual. Next slide. These are the existing codes. And in this case, 99211, because it doesn't require the presence of a physician, is probably too low level a code. And again, I've got the prices for both inpatient and outpatient. Next slide.
Maura, I just want to correct you. You mean like outpatient facility versus facility fee, correct? Not inpatient versus outpatient. Okay.
Okay, yeah, I'm sorry. Yes, that's true. Okay, now I just want to let you know that there is an opportunity to use time for your E&M and not have to worry about satisfying all the definitions, the review of systems and things, when counseling or coordination of care dominates the encounter. So when more than 50% of the encounter is counseling or coordination of care, you choose the amount of time that you spent, the total amount of time, and then how much time was providing counseling or coordination of care. Next slide. So again, this is explaining that 50% of the time was spent. This is how the documentation would look in your system. I mean, in your progress notes. Next slide. I'm just letting you know, some people are teaching Qigong exercises or Tai Chi exercises, that type of thing. This is the code that you'd use for that. Next slide. Typically, when you bill, you use point of service code 11. That means it's performed in an office setting. Interestingly, most insurance benefits will state acupuncture must be performed in an office setting. Well, here's an opportunity, because you're not in an office setting. You're going to use the O2 telehealth. Some carriers are also requiring a modifier. Next slide. And the typical modifier that we're going to be using is 9.5. I just want you to know there's other modifiers, and go with what the carrier tells you. It's in most cases, it will be O2 as the point of service and 9.5 as the modifier. But if they tell you to use something else, use what they want you to use. Next slide. So you have, if you're going to even consider billing it out, you have to make sure the patient has benefits. And then you have to make sure that it's a covered diagnosis. And then of course you go with what the carrier determines how to properly bill it out. Next slide. So you're going to look to the carriers for instruction. You just can't assume that they all are going to allow telehealth. Some of them have that teledoc already included, and so they're not as likely to open it up for, especially for acupuncturists, unfortunately. So don't verify the patient's benefits and ask them, does he have telehealth? Because this is a new area right now. People that didn't have specific telehealth benefits now have it as they've opened up based on COVID. So now you also need to understand that what Aetna does or what Cigna does as a policy can be different for self-funded plans that they administer. So you can't assume, if you're talking about a self-funded benefit package, you just have to make sure that they're following the direction of the carrier. In most cases they are. They want the patients to get that treatment, but just double check it. Next slide. This is an example of how you would do that. You're going to go to the major carriers and you're just going to look and see. And then I'm showing you this slide because I want you to go back and continue to check at a frequency, because look at, if you just counted on what happened with United Healthcare, I pulled this up back in March and they said that they were going to discontinue the services after June 18th. They've since changed. They're now up to September. But as we go through this time period, keep checking back to making sure that what they're allowing and the amount of time that they're going to allow you to provide these services are still adequate. Okay, next slide. So make sure your state allows for it. Make sure that you code for it by determining the carrier's policy first. The patients have to have acupuncture benefits, and the diagnosis still has to be a covered diagnosis. If you're going to do digital or telephone, it's got to be an existing patient. And what we're finding in some cases, they're limiting telehealth to in-network only. So that's another question that you need to ask. In all cases, you're going to want to verify the information before you treat the patient because things are changing rapidly. And that's it.
All right, thank you very much, Maury. I appreciate that. And Maury, there are some questions for you in the chat. I'm going to pause here and pull up slides for Nancy. Please welcome Dr. Nancy Gales, Wellness, Education, and Telehealth and Harmony CEO. She's a policy consultant for the Integrative Health Policy Consortium, and she is our expert today on our panel for federal health policy. Welcome, Nancy.
Thank you, and thank you for having me. This is a very interesting conversation, some of which I knew already and some of which I didn't, so very interesting, and I appreciate the professional wisdom sharing. So yes, I am a chiropractor, a certified classical homeopath, and an ordained interfaith minister, so I dwell in body, mind, spirit areas of care and legislation advocating for policy changes that include these healthcare initiatives. So that said, I'm representing the Integrative Health Policy Consortium today, and my client that I represent on that board of directors is the Council for Homeopathic Certification, from where I learned everything about telehealth as when I was president of the National Center. So here we go. You can move, yeah. Okay, so you acupuncturists will know with every crisis, there is opportunity, and every cloud has a silver lining. The coronavirus has made rapid changes in federal policy, reimbursement, and definition, languaging of alternative and integrative healthcare providers that we have worked for many, many years to try to achieve. So it came into play out of necessity, as often happens. And that was the HR 748 CARES Act, which was enacted on March 27, 2020 into law. So this is a law. Now, here are the provisions of it that may or may not apply to your hospital-based programs. I'm just going to outline for you what the federal policy, what the law is now. And if you're not aware of it, you can look it up and then decide if it's applicable to your program, or if you want to bring it to the attention of your administrator. So the first thing is that for hospital-based acupuncture programs, these provisions may be applicable. First of all, there is money allocated, $130 billion to the medical and hospital industries. That's up to them to decide what they're going to do with it. And I don't know, it's not written into the bill, into the law now, as what exactly you have to use it for, but that would be something that your administration decides. It reauthorizes and allocates funding to public health programs. So this is really important. And what I did is a check with CDC about how is telehealth viewed as a public health initiative, as a public health tool, because that is really important now going forward. We're looking at all types of public health issues based on security, health and well-being, social distancing, etc. Public health initiatives are really strong. So when you're using telehealth as a tool to advance that public health initiative that the government has already made a law about, they like it. So that is, you get funding for public health programs. You want to kind of tweak your program to be a public health tool, because we know that it significantly increases access to health care for medically underserved population, as well as widespread belief that it can reduce healthcare costs and improve health outcomes overall. It's no longer a belief. We learned through this epidemic that it's true. And we do know that the medically underserved communities, as well as the racially disparate communities who often can't access regular medical care because of the other issues identified earlier, were the ones most affected. And so it has come to the attention that we really do need to serve them in the best way that we can. And the outcomes are good when we do that. And they do tend to follow at home better. And so it's a good time to have this policy in place as a law, and for you as your hospital-based practitioners to start to move that forward in your own institution. It also authorizes the FDA to approve rule changes for over-the-counter. This is wonderful. I personally have worked on this for many, 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 many years. In the Obama Care Act, they took away the opportunity for you to purchase over-the-counter remedies, in homeopathic particularly, that I look at, and as well as menstrual products, menstrual pain relievers, ibuprofen, and in your case, the Chinese herbs and products, that you would have to go to your medical doctor first, get a prescription for your $7 bottle of ibuprofen in order to have it be deductible from your health savings account or your flex spend account. So this now is changed. Now you can do that with that. I noted down here. All health savings accounts and flex spend accounts, reimbursement accounts, and medical savings accounts are to pay for or reimburse over-the-counter medicines without a prescription or a note from a physician. And you'll notice that in the federally qualified medical deductions, acupuncture is listed as one of the services for health savings accounts and flexible spend accounts that is a legitimate deduction, but maybe sometimes you need a note of medical necessity from a physician if you're not one. So what this CARES Act does is take that away. People are empowered, thank you, my favorite thing, self-empowerment and self-care. And that is that they can, with the advice of their acupuncturist in this case, be able to take that prescription and have it deducted from their health savings accounts, which is great because everything alternative, shall we say, or out of the medical prescription field isn't always covered by insurance. So in this case, changes were made to allow you to do that for yourself. So you also get $145 million in grants over a 5-year period for promoting telehealth. That again is up to your hospital to decide how you're going to do that, but you can apply for those kinds of grants. The increases in Medicare payments to medical providers from May 1st, 2020 and through December at this point as an increase in the medical payments for that. So they're giving you more money to do telehealth. There's also relief to business and organization in the form of loans, paycheck protection programs, tax credits, etc. I'm sure your facility has already been aware of that and hopefully received that. And for individuals who are working as acupuncturists, you are also get relief from those same things. Go ahead to the next slide, please, Megan. Okay, so the initiatives from IHPC are intended to expand access to the integrative healthcare practitioners who prescribe these products, including asking for a change in language. So for instance, the language as it is now, and I'm just pulling up my own screen on here, says that you have to be medical expenses include payment for legal medical services rendered by physicians, surgeons, dentists, and other medical practitioners. And IHPC was, and we are working on expanding that language to include integrative healthcare practitioners. So we have a policy statement, you can find it on our website, that includes state licensed, state certified, and nationally certified practitioners when their credential is accredited by NCCA ICE, which is a federally recognized gold standard of certification. Now, this may apply to some educational levels of acupuncturists, and I don't know those designations. I know from my particular client, the homeopathic profession, we are a hybrid of medical doctors or chiropractors or any state licensed practitioner who practices homeopathy within their scope of practice. We're also nationally certified practitioners, which means you can be and not have a license in one of those medical professions, but have attained a national certification when that educational body, that system that you studied with, that school that you studied with, is accredited. Their national exam is accredited by this organization. And why is that important? Because the federal government recognizes that that accreditation has standards of excellence, education, ethics, accountability, and is of safety to the public and non-invasive, no harm. And so that is a very important credential to have. And we brought that to, IHPC brought that to a congressional briefing. I'm going to say maybe almost 10 years ago now. And we have continued to recognize and promote for nationally certified practitioners who do not have to be state licensed. So this is really important. And why? Because finally now, and this is not on here, but I will tell you this, May 1st, 2020, the CMS, Megan is going to send you this information so you have it for yourselves, because there's some new rulings that came through. They're coming through fast and furious. CMS, Center for Medicaid Services, are not doing their regular annual rulemaking anymore, which means you used to have to apply, get them to change the rule, to make any language change. They're accepting requests now to do that. And they're moving through very, very quickly. So I'm going to just go through some of the current legislation that just came through May 1st. The first one is just what we wanted. They updated their interim final rule that expands Medicare coverage for telehealth. Okay, that's not the one I want to say. Here. For the duration of the coronavirus PHE, we don't know how long that will be, but so far now it's extended through December 30th, 2020, but it is previewing to be not only extended further, but adapting different language that we want and accepting that. Okay, sub-regulations it's called. CMS is waiving limitation on the types of practitioners that can furnish Medicare telehealth services to include all practitioners that are eligible to bill Medicare for their professional services. So for including physical therapists, occupational therapists, speech language pathologists, etc. So not just licensed medical doctors. Prior to this, as I said, only the physicians could do it. Newly eligible providers still do have to comply with their applicable state practice and licensure requirements. I'm looking into understanding if we can still now put in for the national certification and state certifications as well. So we're going to try to do that through IHPC. They have changed the payment models for remote physiologic monitoring services. For purposes of treating suspected infections, they're going to be allowing a remote physical monitoring services to be reported for days different. I'm not going to go through all the language, but they're making changes in the remote monitoring allowances. Audio-only telehealth services are being waived. They waived the interactive audio-video requirement for certain telehealth E&M services, enabling providers to bill Medicare for certain services delivered by audio-only phone. So beneficiaries of Medicare will now be able to use audio-only telephone access because, of course, a lot of them don't have computers or are not computer savvy. And there is a list of eligible Medicare telehealth services on this website that Megan will send to you.
All right, thank you. Nancy, we are at the end of our time, so I will send that to the
Send that out. Okay, great. Thank you. I appreciate that. I just want to say one thing, that there is access to also federally qualified health centers. You wanted me to mention that they will reimburse for Medicare telehealth from there. And the last thing I want to say is if you go on this website, IHPC, we have a congressional caucus for integrative health and wellness that is a bipartisan chaired caucus. And if you can go to that, take a quick look at it and ask your congressperson to populate that, we can get a lot of changes. And the co-chair Judy Chu, Representative Judy Chu, has already, she's very, very, very much in favor of acupuncture and has already pushed through on lots of legislation. So it would be a really good to support that. Thank you. Amen. Hallelujah. Thank you very much.
Yeah, thank you very much, Nancy. I just wanted to mention, you said in your previous slide about ICE, the NCCA ICE, The acupuncturists, our national board exam, NCC AOM, is accredited by NCC ICE, and that is one of the reasons why for federal practice you need to be NCC AOM certified for a lot of the reasons that you listed.
Beautiful, wonderful, thank you.
All right, I'm going to switch over to panel discussion. So one moment. All right, so I'm in the process of pulling up the slides that have the discussion prompts. So before we do that, panelists, do you have any questions for Nancy?
I have one question. This is John. Hi, Nancy. Great presentation.
Hi, John.
I'm learning so much. In regards to that new CMS ruling, you spoke about Medicare will cover all practitioners from PTs, OTs, speech. Was acupuncture included in that or not yet?
There is a list provided there, and I don't see let me just check. I just closed that screen. Let me just say. As long as you're state licensed, you're going to be, okay, those are the codes. As long as you're state licensed, I'm sure that you're included. Well, I shouldn't say I'm sure. The convert, yeah, including physical therapists, etc. Go to that list of services and it's going to tell you. But because acupuncture is already a eligible IRS code, it's an eligible medical, IRS medical qualified expense, then there shouldn't be any reason why you're not included, even if it's not listed here, because you are already in the code.
Great, thank you.
Sorry.
Nancy, the second question to reiterate on the previous one, by your knowledge, how soon that new rule covering acupuncture under Medicare paying for acupuncturist should start? Is it next year start or?
This is part of the COVID and it's immediate, May 1st. May 1st were this final ruling that came out. Yeah.
And is it just for the COVID emergency time or it will be a permanent rule?
It does not say that. It says just for now through December 30th. What your job is with your associations is to do the policy work like we do, is to make sure, because right now they're accepting, they're taking requests on a rolling basis for language, sub-regulatory language. So you want to get your association in there saying, hey, this is great. Look at the cost savings. Look at what we're doing for health outcomes. And we would like to make this a permanent rule. So that's the part of follow through. Right now, these are interim rules that are made for COVID. And then you have to follow that through to make sure that they don't go away.
So my understanding of the situation, which may be incorrect, and Nancy, if it is, please, if you know differently, please correct me on this, is that CMS had given us access. You know, they said, yes, we're going to cover acupuncture for low back pain. Here are the requirements. But we were not yet able to become enrolled providers with Medicare, which I understand to be a different process that I think has to go through an act of Congress. And so, can you kind of speak to that?
Yes, that does have to go through an act of Congress. What you could start thinking about, however, is they did with this final rule, consider bundled payments now for opioid treatment plans, because the COVID epidemic has really highlighted the fact that we're also working on the pain addiction issue, and they really want to resolve that too. So this is a time when you can start bundling up your acupuncture and opioid pain and sort of start talking to that, to what they already made an interim rule on, and start playing it through and saying, well, in order to do that, we need to be added to the list. And can we go around? There is something, and I'm forgetting the name of it right now, where you can bypass that rule of Congress and go in as an immediate emergency thing. I'll have to check with one of my colleagues on that. He did work with CMS for a while. So it matters that you have your organizations work in a policy group. So come on board to HPC.
Yeah, Wonderful. So I will send out more information about IHPC. Nancy, you probably don't know this, but for those of you who are on so one of our national groups is the American Society of Acupuncturists, and they have been co-hosting a discussion series. I think it's on Wednesday evenings, and next week, Wednesday evening, it's specific to Medicare and acupuncturists. So they will be doing a very long session on just what acupuncture as related to Medicare is all about. So I recommend you guys check that out. And then we're gonna move to some other topics. We are a little bit short on time. Those of you who need to leave by 11 o'clock, go ahead and leave. Those of you who are really in the middle of discussing a really interesting topic, go ahead and stay. I will extend this about 10 minutes if we need to, but otherwise I will try to stay on topic and on time. So the first big discussion question that came up is workload. So for those of you who are doing telehealth, what is your, I'm going to start in order as you see the panelists here. I'll start in the upper left corner and then go down to Paul, John, Julie, Galina, and then if Maury and Nancy have anything to add to something, I will highlight you as well. So first, going to Paul, what % of your time or of your teammates' time is spent in workload for telehealth now versus what it might have been earlier in the season?
So at Penny George, still have most of our inpatient providers doing nothing but telehealth. Although, like I said, within the next 3 weeks, we expect that to transition pretty quickly into in-person services again. At the moment, we're probably seeing maybe between the rest of the outpatient acupuncturists, at most 1 to 2 patients a week throughout our system, not just per provider, because we have reopened in-person services with all the PPE and safety adjustments, and we're getting flooded with people coming right back in.
All right, John, can you answer that question?
Yes, the percentage of telehealth visits is minimal. We are work from home, and as I discussed, we have different programs. So as their work from home requirements, it's basically 10 to 20% of reaching out to patients. Ideally, by the end of the year, we'd like 50% of our visits to be telehealth.
Okay, cool. And Julie?
I would say it varies substantially between sites. I'm aware of some acupuncture providers that are seeing 6 to 8 visits a day through telehealth, are really, really active in telehealth. I'm aware of a lot of providers, as I said, who are doing some group classes. They could be Tai Chi, Qigong, those are the ones that I see most often, and some mindfulness classes as well. Then I have other sites that are, seeing a smattering of them, 1 to 2 a day. And I also have some sites where they still have had some difficulty setting up the actual clinic for the licensed acupuncturist, just because there's a difficulty in their understanding of what could be billed by that provider. So some that aren't doing any telehealth at this time. And we have been reassigned to many different areas. People are doing, check-in, physicians are doing check-in at the door too. So it's something that if you're in the labor pool because you're not able to see patients, you might be, next to the surgeon who's not able to practice right now, doing temperature check-ins at the doors. So that's
okay. So big variety for you there.
yeah.
And Galina, I think I understood from your discussion that from your presentation that you're doing telehealth for Chinese herbal medicine consults only, no other type of?
Correct, that Chinese herbal medicine consults only, and my load did not change due to COVID at all whatsoever, since logistics does not allow us to attend acute infectious illnesses, just because outsourcing shipping, it takes about 3 business days for herbs to arrive to the patient. So we are not seeing acute patients, and my chronic patients load remains exactly the same.
Okay, So panelists, do you have questions for each other on that topic, on workload related to telehealth? Okay, then I'm going to go to a question about sustainability and reimbursement. So the question is about sustainability of program and buy-in from patients, such as patient demand for services. What is the buy-in from patients for your telehealth program? Is your program sustainable? And how do you know it is sustainable? Okay, I'll start with Paul.
Sure. You know, I think in terms of buy-in, we've got certainly a mixed bag. In our outpatient setting, all of our patients that engaged with us were already very engaged in that relationship already, and we're very much thinking of it as a sort of a placeholder. I think everyone in the outpatient world wanted to come back in as soon as they could. In inpatient, we are getting a decent amount of engagement, although you know, there's still some disappointment when they learn that we're not actually going to be coming into the rooms to put needles in once my providers have called them. I don't know that this is long-term going to be something that our system tries to sustain very much, although I can see it being kind of a niche thing that it would be a good thing for us to use, say, for rooms with contact precautions if something is really, even going forward post-COVID, or patients that are on herbal therapy that live a long way away from the most local provider. But I don't necessarily see it being sort of a large amount of our bandwidth once we get past the pandemic.
The telehealth part of it, you mean?
Yes, the telehealth part of it.
Okay, and then what metrics are you tracking?
In inpatient, what we're tracking is number of calls versus number of patient contacts, and then once again, just the metrics of those people that we've actually spoken to.
Okay, and then clinical metrics, I think you had mentioned earlier that you,
Sure.
nausea scores, pain scores, what else?
Yep, nausea scores, pain scores, anxiety scores, and coping scores is just sort of a generalized question that we ask. And these are things that we've been, it's sort of the standard that we've used since 2003, when we were first starting in the inpatient world. So
Okay.
that's just sort of the model that we used. We just rolled it over to on the phone as opposed to in person.
Thank you. And so John Burns, I'll give that question to you since that was a question that you had posed for the community. Do you have any other questions for Paul related to that?
No, that was great, Paul. Thank you for that. We really don't know what the sustainability is until we find out what third-party payers are going to do. Mm-hmm. Obviously, our complimentary telehealth visits are well received because it's complimentary. But moving forward, we want to make it a valuable, billable product, which I think we can. I come from a Western medical background as a physical therapist. I know what physical therapists offer in their online visits, which is great, but I think we can provide very similar one-on-one presentations as well as all of our other modalities, from mindfulness to Tai Chi and Qigong. I think it can be sustainable, and I think it will be because consumers want this, but I don't know yet, so that's the problem.
And Julie, your presentation was a lot about how the VHA, the Veterans Health Administration, already had a lot of telehealth in place because it is so important for veterans for being able to access care. So do you have anything to add?
You know, I would say that our patients have a greater culture of acceptance for telehealth, and we also, send them iPads and equipment and things so that they can do these virtual visits. And I feel that that helps keep them connected that way. And, you know, they met with their physical therapist last week via telehealth, and they met with their primary care provider via telehealth. So I think there's just a deeper understanding already with the veterans of how to use these platforms and what can be done with these platforms. So I think it's very interesting to see that there already is some understanding. The patients already know, you know, how to use the equipment. We also have things set up, like I was talking about that emergency plan that we have. That's a part of the electronic health record, that there is an emergency plan that's created. And so usually that's already in there for the provider. So it's, you know, you already know that they have an emergency plan. In terms of tracking, we're doing some things kind of behind the scene to show how many encounters are being done by acupuncturists with telehealth. I think we had something like 250 to 350 encounters in May and March. I'm sorry, in April and May. And so we're kind of curious to see what happens with those as inpatient care continues to ramp back up. But we still have a lot of rural veterans and highly rural veterans. So being able to connect with them as a follow-up is really important for us. For if you have an inpatient appointment and you teach them some self-care strategies, there could be a virtual visit follow-up. We also are finding a lot of our providers are enjoying doing an intake, getting their past medical history, talking to them, you know, doing some acupuncture education, doing that via telehealth. And then when they come in, it's just the needling and the hands-on treatment that might be done. And maybe you've already taught them an exercise, so you could review that when they're in person. And we feel that this can speed up the clinic time and the number of patients that might be able to be seen in clinic by doing that portion ahead of time.
Oh, wonderful. Thank you for that explanation. Galina, do you have anything to add about sustainability of the program? It sounds like, you know, my understanding from your presentation is that the Chinese herbal medicine through telehealth has been very sustainable for your program. Do you have anything to add?
Yes, it has been sustainable since we are not new to telehealth realms. Just before COVID, my patients had a choice between telehealth or in-person appointment for herbal appointments, since it is a separate service. It's not intermingled with acupuncture services. Now they don't have a choice. They were mandated to do virtual follow-up. Some patients did have some resistance, especially older population, but we all adjusted, we all can do it. And now we are back in practice seeing patients in person. We do, at the current moment, outpatient only. We did space patients out, so we are at approximately 50% capacity, but telehealth has no problem with sustainability for us. Though our shared medical appointments, like one of them which had acupuncture included, our chronic pain SMA, then it's 8 weeks, 4 hours class, and acupuncture service was part of it. As educational aspect of that, on the first week, I was speaking about acupuncture in chronic pain management. On the 8th week, it was introduction of herbs, especially topical herbal products. We are now toying with the idea to have it available via telehealth, and obviously an acupuncture, we use NADA protocol every day of that program will not be available, but educational component probably still will be included even in our telemedicine shared medical appointment for chronic pain.
Okay, and then I have a topic, one of the topics that came up on and off the last couple of months was using telemetry. So it's using like remote patient monitoring or telemetry. So we know physicians use it regularly in different settings, but as acupuncturists working in the system, whether you're inpatient or outpatient, are you also tracking any information from telemetry? So I know Galina gave the example of how when she does the CHM telehealth, of tracking heart rate, like that visual graph. That's correct. Galina, you do that most of the time?
It's
Or?
actually not necessarily heart rate. It's a full interpretation of mobile EKG based on TCM principles. So on EKG, you can see the qualities of the pulse as well. And
Okay,
it's
so
perfectly describable in TCM language.
so it's an
More
echocardiogram.
information on my website on that subject.
Right, and so that's an echocardiogram printout
Just
you
simple
showed us.
EKG, one lead mobile EKG.
And you're getting that from like a patient wearing an Apple Watch or
Yes.
Fitbit?
That's an Apple Watch, or a patient purchases Cardia Live electrodes. It's
Okay,
just one-time purchase, and app is free.
and they are able to give you that data to upload to your
Yes.
chart. Okay.
And they just upload it via secure American Well portal.
Okay. Paul, John, Julie, do you have any notes about using telemetry like that in your systems?
We are not using anything like that. I think it's a little bit back to the barefoot doctor minus pulse. We're still able to do tongue, but more on signs and symptoms.
I would echo that. We are not using telemetry. Would be something I'd like to look into as we move forward. So not currently.
So yeah, nothing remote telemetry for us either, but most of our telehealth presence is with patients who are checked into the hospital, and we're working through Epic, so we're working through the EHR. So anything that's being recorded in Epic, our providers have access to.
Yeah, I would second that. We have a lot of patients who are seeing a home-based primary care provider.
Mm-hmm.
So they will often have a health tech or a nurse or the physician that goes to the patient's home, and there could be a lot of information that's in the electronic health record based on that would be of value to the acupuncturist.
Okay, so as licensed acupuncturists in your systems, you may not be recording those telehealth or telemetry, but you do have access to the data that others are recording in there. You have access to that part of the note.
Yeah, and if a patient could have a at-home blood pressure cuff that is linked with telehealth, and if you were on the phone with them and you wanted, or on the a video connection with them and you wanted them to take their blood pressure right then and there, you could, but it's available.
Okay. I mean, that answers a lot of the questions that we had on telemetry, which you guys just brought up. So we covered some of the basic topics except for billing, coding, and reimbursement. So Maury is our expert on coding and billing. I just want to note that Dr. Nancy Gales has left the discussion, but we did get a lot of federal questions with her earlier on. I'm grateful for that. So panelists, do you have questions for Maury about coding, billing, reimbursement, or specific state information related to that?
I have a question, Maury. Thank you for a wonderful presentation. I've sat in on several of your presentations and they're very informative. What we're looking at is what the carrier for our team members has recognized and potentially will reimburse for. That is the 98970. These are the new codes for non-physicians. Are we to try to push forward the use of the 99421 to the 99423? I believe, are those not more for physicians or qualified medical providers, especially working out of a hospital?
The 7 codes that are E&M codes for non-physicians, if you're in a state that doesn't allow you to bill the other codes, then I would say you would have to use them. It's more of a Medicare thing. I'm going to tell you that we're seeing the true E&M codes and the telephone codes being reimbursed. It wasn't that way in the beginning. In the very beginning, it took a while for the insurance carriers to get up to speed. So we've had to do a lot of sending back for reprocessing, but we are getting the codes that I showed you, those 3 types of codes. I don't have a lot of data on digital one, and I'm taking my data from the clients that I have. I have close to 200 clients, and a lot of them are doing across the country. A lot of them are using these codes and getting reimbursed. So I would suggest unless the carrier states they're not going to accept the codes that I told you about, then you'd revert back to those 7 series codes. But I'd try to see if most of the major carriers, commercial carriers, are paying for the codes that I described.
Thank you so much.
Sure.
I have a question. So we're doing a lot of teaching acupressure, and there's a lot of discussion about whether or not we call this can we use a massage code when we're teaching it, or if it's really just an education code. This is a constant debate.
I'm gonna say you're not gonna be able to build a massage code, and you're just not, because you're gonna have to provide the service, unfortunately. So yeah, it would be an education, and I don't see any reimbursement for those codes right now. I mean, I'm not super familiar with education codes, but I know what they do cover when providing acupuncture services, and that's not something that's typically covered. But I do think that there is potential for the 97110, the therapeutic exercise, and if you are teaching the Tai Chi or Qigong for stretching, strength and endurance, functional improvements, that code should be built. And we've seen that code get picked up and paid. Sometimes it's a fight, because, they introduced the fact that, hey, we're going to pay for telemedicine, but their databases haven't been updated. And then if their databases do get updated, do they think to include your provider type? So I'm not going to say it's been super easy to get reimbursement. We've had to kind of educate the carriers, but we're seeing reimbursement for that as well.
Julie, I just want to add the caveat. So Julie's at the VHA, so they're what Maury's talking about is for third-party payer reimbursement is her experience with that. And so Julie, you're dealing with both what the care you provide is whatever the VHA does versus what gets reimbursed, or is it you're talking about both things?
The coders want us to code in a way that's appropriate for any third-party payer. So it is possible for a veteran to have an outside insurance that could be billed. So all of our coding has to be done appropriately, that if any veteran that we saw has that third-party insurance and the VA were to bill it, that it's all done correctly. And it's also how we track all the care that we're doing is through the CPT codes.
It's a good clarification. Great.
Maury, as well, there is a little bit of the confusion among the community on telehealth codes. Are they a consult code or they are a procedure code? And in the notes, do we use a statement that more than 50% of the time was spent on patient education and counseling, and that's what makes it time-based reimbursable code, independently which service we provided? We were talking about patient symptoms, or we were teaching them Qigong or acupressure? Is it correct?
If you're going to bill E&M codes based on time, then yes, you're going to want to, the documentation would require that you document the total time you spent with a patient. So you might be questioning them and asking them, certain, things about their history, history of present illness and things like that. But the majority of the time, they start asking you a question and you start to go down in a different direction, providing counseling or coordination of care services. And then you just look at it. If the total amount of time was 30 minutes, of which 16 or more was spent providing counseling or coordination of care, then you bill the proper E&M code based on time. And that's all got to be in the progress.
That's specifically in regards of telehealth codes.
Now
since that is essentially what we do in education and counseling.
Yes. That I really can't say. I would say in all cases, I don't think you necessarily have to to provide 50% of your time providing counseling or coordination of care. You want to do the best that you can to provide an E&M service, but it could be a low-level E&M service. They're not saying you have to hit all these bullet points. So you might provide a low-level E&M service, but you're just going to price it out based on time, which is actually what they're going for next year. When they change the E&M requirements, they're going to be based more on time anyway. So did that answer your question?
Yep, thank you.
All right, so because we're near the end of our time, I just want to end on a few things. One more question, and then after that question, I'll just give you each of our panelists time to give their last ending note, whatever that is. So so as you guys have been setting up these telehealth programs, tell us what your biggest issue is, if you overcame it, how you overcame it. And then the third part is if you still have an outstanding issue, what that is. And then let's go ahead and do the ending note as your fourth thing after that. Like what is something you would like to end on today? So we'll start with Paul. You guys want me to repeat that?
Yes, please.
Yeah, okay. That was 4 things, right?
Yep.
So I'm on issue. So as you guys have been setting up these programs, what was an issue that you came across or a barrier to being able to set up the program? How did you overcome it? Are there outstanding issues you have? And then a positive note to end on for today.
So, one of the issues, probably one of the largest issues that we had going into this is much like Julie found, and I'm sorry if I'm stealing your thunder here, Julie, is the fact that it was an entire shift of paradigm for acupuncture in these systems. And everyone looks at us as the acupuncturist. We're the needle people. I've got physicians that refer to me as Dr. Needles, which is obviously not my name. And it was I think it was our entry point into these systems is we do acupuncture. It was something that they could get their minds around pretty easily. And our culture has sort of been built up around the fact that we stick needles into people. And it was a big cultural shift. I was even having to struggle with some of our very immediate leadership, like the operations manager that I work with on a regular basis, who's a huge supporter of what we do, just convincing her that no, we do more than the acupuncture. And it's billable and it's reimbursable and it's worth us pushing onto these other forums. And so it's still an awful lot of work we have to do to sort of expand our practice, because I think we got, and partly that is sort of showing up in, I think a lot of the struggles that all of us are dealing with in terms of the types of codes that we can still bill. We started with the acupuncture codes, which is wonderful. And we're sort of muscling our way in right now into the E&M codes for where we are in our system. Getting the Tai Chi codes, getting Tai Chi to be codable and billable, getting food therapy, herbal therapies. These are all sort of growth areas for us to use. And once we can move into those other venues more easily, it's going to be very easy for us to continue to justify telehealth, because it's not just needles, as John was saying. So now that I've stolen everyone else's best lines, I'll turn it over to someone else.
Thank you, Paul. John?
Thanks a lot, Paul.
Well, you guys can repeat each other, because if you are encountering the same things, like that is just a wonderful thing to be able to say, hey, yeah, we had that experience too. So please don't feel like you're repeating each other. You're telling from your own experience.
Yeah, the same thing. It's the biggest issue is educating the stakeholders, the people who have approval rights, to why acupuncturists should be able to provide telehealth visits. And it goes back to this understanding that we are more than needles. And I am so proud of the TCM education I received, the benefits of Tai Chi and Qigong and acupressure, you name it, and how we can share this with patients. How I was able to overcome the pushback was to reach out to all the physicians that I developed relationships with over the years. So I worked with surgeons and psychiatrists, fellows trained in integrative medicine, and I asked for their support to see if we could get this approved by our service line leader. And guess what? They approved it. The outstanding issue now is coding. And you may think it's easily done, excuse me, but we have policies in place for hospital and policies in place for ambulatory care or outpatient care. They're different. So we have to come to some agreement how we can bill in the hospital similar to how we bill in our outpatient clinics. So that's the outstanding issue I'm up against. As far as a positive note, I would say COVID-19 exposed humanity's vulnerabilities to this virus that we really were not aware of, how important it is for everybody to take some control of their health. These chronic diseases, obesity, diabetes, their heart health, chronic lung diseases, many of these are modifiable, and they can be modified by people taking action. And I think the actions they can take can come from education from TCM acupuncturists providing that pathway. So I think that's going to be the silver lining, as I mentioned earlier. We are positioned to help address this current situation and to hopefully prevent another surge in the fall by getting people up and ready to work on their own health as they're isolated. So that's my positive note.
So lifestyle modification factors and the ability to teach patients self-care in a variety of ways. That's wonderful. Thank you, John. Julie?
I agree that the biggest barrier was having the system understand what the value of the licensed acupuncturist is. And what we did, and I have to say that in retrospect it worked, but it wasn't my goal that this is the way that I was going to overcome it. We just were at the very onset where we wanted to get content out there. We filmed a bunch of acupressure videos. We created more acupressure handouts. We had community of practice calls with all the providers of acupuncture. We talked about how we were going to do this. We got together and thought about it. And, I think that we created this workload for ourselves that we were able to deliver to patients. And then I would get, I got invited to speak on a lot of different community of practices calls through pain management and primary care and all these different other groups, so that we're really seeing what we were doing and wanted part of it, and said, can you send us those acupressure videos? We want to show those to our patients when we're on a telehealth appointment with them. So we really bled into a lot of other people's work too. And I think that's a great thing to do, is to be able to share our medicine that way. So the difficulty was that understanding what acupuncturists did, but we were able to show it through these different platforms and make it a broader part of the system. So, and I hope telehealth is here to stay. I think it will be to some degree, but at the same time, in VA, the healthcare system wants us to be there to be treating patients in person. So there's going to be a give and take of seeing how it will fit in the future.
Thank you, Julie. And to you, Galina.
So, though I'm not a VA part, but it was very interesting when I was researching the law of practice across the states, was interesting statement from VA that VA declared telehealth mission critical, and VA as a system allows their healthcare practitioners to practice across the state lines, which is very interesting. And that's maybe one of the big advantages of VA. On our side in Cleveland Clinic, the difficulties which we faced, obviously not being able to provide in-person services and administrative slowness of the system to switch behind the scene administrative stuff is oh my God, we just not fitting in time frames. COVID is too quick for us, and we are like a snail, which is too fast paced for us. But on the good note, by the end of the year, hopefully my herbal research, and it's a safety research and clinic practice model research, shall be published in Journal of Complementary and Alternative Medicine. In that research, I compiled 6 years data of safety of usage of Chinese herbal medicine and described our practice model, which any healthcare system can take and implement. So please, guys, I will share my research with each of you personally. Share with your systems. And herbs are so easy to practice via telehealth. It doesn't matter. Patient doesn't have to come in person to see me for herbs. This way we can access even the most remote patient. And it's a great advantage of our medicine. We can adapt and adjust to everything. We survived many millennia as we are, so we will survive the COVID and we will help patients the best we can. Thank you.
Wonderful. Thank you, Galina. We are looking forward to seeing your work published. All right, Amori, do you have anything you'd like to end on a positive note today?
I deal with insurance companies. How positive can it be? This is a bad one to end with. No, I just a couple of things, just maybe more like tips. Well, one thing I'll tell you is a lot of times, I mentioned it in my slide, a lot of times you see hospitals that are really reticent to bill for acupuncture services because so many policies will state must be performed in an office setting. So right now, telehealth throws that out the window. So here's an opportunity to go back and revisit that. I'll also tell you that in hospitals, acupuncture, you can get people's benefits quite easily through the web, almost instantaneously. But stuff related to acupuncture, you really have to dig down deep. And so I think a lot of times they don't think there's coverage when in fact there is, or they don't want to take that deep dive down, or they've had problems with the billing. I will tell you on the insurance company's front, if you have a problem with a bill for telehealth and you verified that the patient does have it, you got to bring the patient in. It's not your insurance, even if you're contracted, it's the patient's insurance. And so therefore you have to have a very proactive patient. And so you want to start that discussion in the very beginning. You know, I'll bill this out. I've checked and you've checked and we have telehealth, but at some point I might need to bring you in. And that's for the near future because, you know, it's constantly changing. So that's my tip.
Thank you, Maury. I just wanted to end on making sure those of you who came in a little bit later that you know where to find these recordings. So when all these recordings are finished and processed, they will be in the online resource module. So if you have a recordings only ticket or a ticket plus ticket in your digital download, there will be a coupon for this. And for everyone else, I will, in the next email newsletter, there will be information on how to access this as well. So it does take me time to process things, so it won't be available immediately, but I will put out an announcement when it is available. So thank you everyone for being here today. This was our very first event, and it is an online event. And I only did this because of everyone's feedback this spring between March and May that you really wanted to have an online public event like this with these panelists that are here today. So thank you very much, panelists, for your time today. And this was a wonderful discussion, and the chat discussion was wonderful as well. And I will have notes about all this, hopefully within the next week, and email that all out to you, or send it in the email newsletter. So thank you, everyone. I really appreciate your time.
Thank you, Megan. Thanks for having us.
Thank you for being here. All right.
Thank you, everyone. It was a great
Thank you.
information.
Wonderful. Thank you all. Have a wonderful Saturday and happy Father's Day.